Hello, and welcome to this lecture on multiple sclerosis, symptoms, diagnosis, and later on treatment. My name is Mashina Chombanda. I'm a neurologist at the University Chin Hospital and the University of Zambia. And we start off by looking briefly at this world map that's from the Atlas of Multiple Sclerosis, which shows a very interesting background to our conversation. It's a map that shows the occurrence of multiple sclerosis around the world. And if you see the very red regions are those with a very high prevalence and reporting of MS compared to those that move into lighter red and eventually orange. And what you'll notice is that countries with gray are countries that are unknown. There is no data from those regions. And traditionally, those regions fall within places like Africa and Sub-Saharan Africa. And traditionally, they're thought to be places where multiple sclerosis does not occur. But you will notice that Zambia recently switched from gray to almost pink, showing that now we have some data on multiple sclerosis from this country, making this subject one of emerging importance or one of scientific curiosity and lots of public health concern, and one that has become very important to discuss. So based on that background, I'll just give a brief history of multiple sclerosis cases, and there's an earliest report or record of a case of MS, and this is as far back as the 1300s, just before the 15th century. And also we've got several descriptions within history from multiple sources of different brain pathologies that were described, but these were most likely MS lesions that were described in those much early scientific days. So what is multiple sclerosis? This is a disease of the immune system. It's an immune mediated or autoimmune disease that results in inflammation and damage of the myelin sheaths within the neurons of the brain. It is thought to be triggered by a number of things. Some are genetic and others can be environmental. We'll also talk a little bit about that later, but some schools of thought attribute this risk to diseases like EBV or agents like Epstein-Barr virus. This immune system results in myelin sheath destruction, as I mentioned, and this can occur in the central nervous system. That is the brain, the spinal cord, and the optic nerves within the nerves themselves. The name literally means multiple scars. So there's multiple scars within the central nervous system, hence the name multiple sclerosis. So it's usually a disease of young people. The age of risk of onset at which its onset is normally reported to occur is between 20 and 50. Sometimes you see it in much younger patients, sometimes in older patients, but it is very much more common in that age range between 20 and 50. It's more common in women than men. Like most autoimmune diseases, it's 2 to 3 times more likely to affect a woman than a man. It is common in, again, traditionally, it is thought to be more common in those who have Northern European ancestry. And they thought that the incidence in African Americans, Hispanics, tends to be, something which is quite poorly understood and not as common. But recent data is showing it to be quite common in these ethnicities. As I mentioned, we have no clear understanding of the epidemiology within Sub-Saharan Africa, but from the West, there is definitely a suggestion that individuals of African American or Hispanic or Native American and with Asian descent tend to have multiple sclerosis. So there's no reason why we shouldn't expect to have multiple sclerosis in Sub-Saharan Africa. So it's also thought to be more common in places away from the equator. So on the world map, it is thought that the further away you're from the equator, the less likelihood that there will be a high occurrence of multiple sclerosis. So its distribution tends to go with increase in latitude. What does it look like? What's a typical case? It is very, very different from patient to patient. That is something to remember of the beginning, just from the start. Just remember that it can look very different from patient to patient. So it could have a patient, for instance, who's 45 years old, is a white male, who's felt fine for a while, and then was diagnosed 7 years ago, and it's been okay. You could have a female woman who's East African. She's quite depressed because of her MS. She's worried about being unable to work, and it's affected her walking and hand movement. So it can be very debilitating in some, whilst others, like Sam in the example above, isn't so affected. Or it could be a 30-year-old woman who's a single mother of two and experience just burning pain in her legs and feet. Can be something as subtle and non-specific as that. Or you could have a 76-year-old man who dies and is found to have MS lesions, and on autopsy and never knew he had MS. Other patients could present with simply tremors, so severe that they cannot conduct simple motor actions like feeding themselves. So a wide range of presentations to bear in mind, that MS can look like anything. It can look different from one patient to the other. And its immunopathogenetic basis is thought to be triggered through, like I mentioned, an antigen from the environment. A lot of studies and evidence could point to potentially Epstein-Barr virus being involved, but the whole immunopathogenesis that eventually ends up in the neuron starts with an antigen-presenting cell that presents this antigen to the CD4 cells. And as you know, there's a variety of, these natural killer cells, and they cross the blood-brain barrier, and they activate further immune actions within the microglia in the central nervous system, leading through another cascade of more CD4 cells within the parenchyma of the central nervous system, leading through B-cell activity. You get antibodies that are triggered. You say the CD4 cells producing cytokines, interferon gamma, and tumor necrosis factor alpha, and you see more activation of oxygen-free radicals, glutamate, and nitric oxide. And all this eventually leads to destruction of the myelin sheath, and in some severe cases, the axon itself. So it's a demyelinating disease of the central nervous system, as we see illustrated in this figure here. Okay, so clinical syndromes can differ with multiple sclerosis. You can get a number of functional systems that are involved. So you can get optic neuritis as the presentation for multiple sclerosis. You can get brainstem syndromes, cerebellar syndromes, hemisensory syndromes, or you can get a transverse myelitis from a spinal cord. And a multitude of patients tend to have a mixture of these syndromes that you can see from the graphs shown on the right side of this screen. You see that patients tend to be more likely to have more than one of these syndromes occurring in one patient. Again, symptoms are very varied, as we saw in the examples above. More commonly, you get fatigue as a very, very common symptom. So this is one that is worth remembering, despite the variable presentations. Fatigue is a very common symptom to look out for and to ask about. Decreased visual acuity, diplopia from the optic neuritis presentation. You can also have blood and bowel involvement, sexual dysfunction, paresthesias, emotional disturbances, mood swings are very common, cognitive difficulties, pain, heat sensitivity, spasticity, gait, balance problems, coordination difficulties from those brainstem and cerebellar problems, speech, swallowing problems, and tremor. This is the wide range of symptoms you can expect from a patient with MS. And as you can see here, these are possible symptoms. Doesn't mean one patient will necessarily have all of them. You can definitely get patients with a lot of them, But don't be surprised if patients only have a few of them. That could still be NS. Again, we saw examples in the different presentations we explored above that you can have a wide range of presentations. The diagnostic criteria relies on a number of things. So you have to have a typical MS-related demyelinating syndrome as one of those we discussed above. You must have objective evidence of CNS involvement, either clinically or on imaging. There must be demonstration of dissemination in space, as well as dissemination in time. And I'll explain what that means later. So there's a patient who presents with this, and in that patient, one must have no other explanation other than multiple sclerosis. And it can be a clinical diagnosis with paraclinical support from imaging, CSF, and other procedures. So remember, a clinical assessment is very, very important for the diagnosis of MS. So there are different syndromes, again, not related to the localization or structural syndrome, but this is rather clinical and radiological syndromes and syndromes of presentation, if you will. And there's two isolated syndromes that one can also present with before the actual diagnosis of multiple sclerosis. So a patient could have a single clinical syndrome of focal neurological symptoms, and after appropriate investigation, it is presumed to be due to CNS inflammation and demyelination. And this symptom must last at least 24 hours and is accompanied by MRI lesions suggestive of MS. And this clinically isolated syndrome is difficult to show yet as having disseminated in space and time. And so what you do is, because you cannot yet show that, you can classify this presentation as clinically isolated syndrome. And it tends to be, in most cases, later on with subsequent presentations to be multiple sclerosis, but it can also turn out to be something else. You can also have the presence on MRI, CNS anomalies within the white matter that meet the standard for the diagnosis of MS. But all you have is incidental findings, or the lesions not necessarily typical, and they may be accounted for by other diseases, and you're not really sure yet if they meet the criteria for multiple sclerosis. So you call this radiologically isolated syndromes. So remember on the slide before, we said that there must be certain criteria that the patient meets for the diagnosis. And if you have a clinical syndrome or a radiological syndrome that doesn't necessarily fit, and it's usually the first presentation or incidental finding, then they can either fall as a clinically isolated syndrome or radiologically isolated syndrome. However, if the patient has actual multiple sclerosis, what will they need to fulfill as a criteria for the diagnosis? So we use the McDonald criteria for the diagnosis of MS, and there have been several modifications, and currently we are using the 2017 McDonald criteria. And there have been some revisions which I'll talk about. And if you have had an attack at onset, then you meet the following criteria for diagnosis. If you be diagnosed with MS, if you meet the following criteria. So if you've had more than 2 attacks over time, meaning that you've had 1 lesion today, and you've had, 1 lesion 3 years ago, 2 years ago, a few months ago, and you have another attack clinically today, that is dissemination in time. So you have got 2 different attacks disseminated in time. This is what I alluded to earlier when I said there must be dissemination in time, but there must also be dissemination in space. So what this means is that there's 2 different areas on your scan that are attacked. So maybe you have a lesion on the right, you have a lesion on the left, you have a lesion in the brain, you have a lesion in the spinal cord. So they're separated by space as well. And so you have dissemination in time and dissemination in space. And the number of clinical attacks you may have is not less than 2. Of course, 2 or above for dissemination in space and time. And you need no further information to diagnose the MS. If you've only had 2 lesions disseminated in time, and you've only had 1 objective lesion on imaging, nothing in space, and if there's a clear-cut history of evidence of previous attack involving the lesion in another distinct anatomical location, so perhaps those 2 clinical attacks, one was in a clinical syndrome of a brain lesion, and then the second attack clinically was one that suggests a spinal cord problem. Yet on imaging, you only see maybe a spinal cord problem on imaging and see nothing necessarily in the brain. And if you are convinced that those 2 attacks fit the criteria for MS clinically, but radiologically you only see 1 lesion, you don't need any further information to diagnose the patient with MS. It is different if you see 2 clinical attacks, 1 lesion that is difficult to separate anatomically, and then you suspect MS. You need to show dissemination in space through additional clinical information that implicates a different CNS site, or do more thorough imaging with MRI to try and see if there's dissemination in space. So you're trying to see if a patient meets the criteria of both space and time. In the criteria or the situation in number 2, row number 2, this one was clearly proven, so that's why we didn't need any further additional information for the diagnosis. The truth remains in the opposite scenario where you only have 1 clinical attack, but you've got lesions on imaging that show dissemination through space. So what you're going to try and do is to demonstrate dissemination in time through additional clinical attacks or MRI, or presence of CSF-specific oligoclonal bands. So that is showing inflammation ongoing within the CSF through these oligoclonal bands that are seen on the CSF. And if you've only had 1 attack clinically and 1 lesion with objective clinical evidence, so you don't really have good dissemination in space and time. So you're going to try to do both. You're going to have to try and demonstrate clinically if there was any attack that implicates 2 different sites within the CNS in the history clinically, or you're going to try and see if it meets the criteria for clinical attacks or imaging or CSF-specific oligoclonal bands. So this is a guide that one can use, and this is if someone had an attack from onset. And again, this is just putting in words what we discussed above. So progression in MS, what does it mean if there's progression? So 1 year of disability progression, that is either you see it happen prospectively or someone gives it to you in the history retrospectively, with or without clinical relapse, would be considered as MS with progression from onset. And so you'd need 2 more criteria for the diagnosis. So you need 1 or more T2 hyperintense lesions characteristic of MS. You need 2 or more T2 hyperintense lesions in the spinal cord, or you need the presence of those CSF oligoclonal bands. So you need extra criteria for the diagnosis of MS with progression from onset. So there were a few revisions that were made, as I said, in 2017. So central nervous CNS lesions had to be separated by space and time. This is the important resolution. Then positive CSF for oligoclonal bands allows for MS diagnosis, where dissemination in space is met. So positive CSF now meets the criteria for dissemination in time if dissemination in space is met. So that's a very important one. And you saw that in our table, that if someone has got good dissemination in space, try to look for CSF evidence to show dissemination in time. Then cortical lesions can be used to show, to demonstrate dissemination in space. So between subcortical and cortical lesions, those are considered now 2 different lesions disseminated in space. You have to eliminate the more likely diagnosis. This was also included. And we need further refinement for optic nerve involvement as well as other populations going forward. So what are those typical lesions that are referred to in the criteria? So this is the images showing typical lesions. You see the image at the top right, top left on the screen, which is labeled A. There are two arrows showing those subcortical hyperintensities. They look white or bright. So those are the subcortical T2 hyperintensities that are just around the ventricular space, and they are in the white matter. You can also see juxtacortical lesions in B, which show just around the juxtacortical territory, but they are still in the subcortical space. And then you can see brainstem lesions or infratentorial involvement in C. You can see that one is in the medulla. And you can see it's hyperintense on T2. And then you can see in the spinal cord itself, that's a C-spine T2 hyperintensity that you can see. Then you see enhancement when you put gadolinium. So you see for dissemination in space, or in space, you can see two different regions involved. For dissemination in time, you can also see a lesion that enhances on T1 when you add gadolinium. So that's the GD you see here. That's gadolinium contrast medium. And you see that it will light up. That shows a newer lesion as opposed to older lesions demonstrated in the images A versus B on the right-hand side. You can also see very chronic lesions which tend to appear hypointense, and these are referred to as black holes persisting on MRI, and these are often lesions that are more than 6 months. So the disease course for multiple sclerosis is often classified into 3 types, and it's often used for classifications of types of MS. So if you have MS that relapses and remits, so you have relapse moments and remitting moments over time, then you have the relapsing remitting type of MS. And you have the disability. Each time you have a relapse, you have the disabilities cumulatively affecting the patient. Whereas you can have a secondary progressive MS in which in the beginning there is no progression, but later on you see progression, and then it tends to have this waxing waning presentation later on. Or you can have primary progressive MS, as I talked about above, where there is progression within just from onset. That's primary progressive MS. So like I mentioned, relapsing disease is one in which you may start off initially with a clinically associated syndrome, not really active, some may be active, and then later on you have the relapsing remitting disease. Or you can have the progressive types, that's the primary progressive or secondary progressive, in which there is some active lesions, some inactive lesions with or without progression. And the commonest you see in most patients is the relapsing remitting type. You have many things to consider as your differentials for MS. Think anywhere within the acronym for differentials, that's the vitamin D acronym, and you can think of AV malformations, CADASIL, infections like cysticercosis, inflammatory processes like sarcoidosis, HTO1V, HIV, syphilis, brucellosis in the inflammatory infectious category. Trauma is a very important differential. You can have other autoimmune diseases, systemic like SLE. You can have metabolic and toxic problems such as B12, PKU, copper deficiency, nitrous oxide. You can have other idiopathic manifestations. You can have the hereditary spastic paraplegia syndrome. You can have Friedreich ataxia, leukodystrophies, which also affect white matter in the central nervous system. You could have neoplasias affecting the spinal cord. You can also have degenerative diseases such as ALS. So a very wide differential diagnosis. And what should make you think that perhaps I'm not dealing with MS? So anything that doesn't really fit MS that can make you think, okay, perhaps I'm dealing with something else other than MS. And these are referred to here as the red flags. So lung involvement, think something like sarcoid, Multiple cranial neuropathies, think something like meningitis. Peripheral neuropathies, think something like B12 deficiency, cardiac disease. Think something like cerebral infarcts, maybe there's a brain abscess, endocarditis. Myopathies, that's muscle involvement, think Sjogren syndrome or MELAS. Cortical infarcts, think of embolic diseases, GTP, vasculitis, meningeal enhancement on imaging. Maybe you're not dealing with MS, perhaps you're dealing with a chronic meningitis, sarcoidosis, or a CNS vasculitis. If you have levodopa reticulitis rash on the patient, maybe you're thinking of antiphospholipid syndrome, SLE, or T-cell lymphoma. If you have calcifications on the CT, then you maybe are thinking of cysticercosis, toxoplasmosis, mitochondrial disease or disorders. If you have persistent gadolinium enhancement, then think maybe there's an ongoing lymphoma, glioma, vasculitis, sarcoidosis. If there's too much headache or meningismus, maybe you're thinking of venous sinus thrombosis, chronic meningitis, lymphoma, glioma, SLE or vasculitis. And if there's myotrophy, then maybe you're thinking of ALS, a syrinx, or a polyradiculopathy. So this is a good way of thinking through your differentials when you have a suspicion of MS. Because like I mentioned, this presentation sometimes can seem very non-specific. So you want to be very sure that you have the diagnosis of MS correct. Then who is on the treatment team for MS? So looking at the treatment for MS, it's really multi-disciplinary because you've seen the symptoms and the manifestations are widespread. So you need anyone from a neurologist to a urologist to a nurse, psychiatrist, physical therapist, occupational therapist, speech and language therapist. You need a psychiatrist, you need a psychotherapist, you need a neuropsychotherapist, psychologist, you need a social worker or a care manager, and you need a pharmacist. And we'll see why when we look at the individual treatments. So the approach is essentially to treat all the symptoms with all the disciplines above. So that would be symptomatic treatment with all the disciplines above. And then there's an approach towards disease-modifying therapies. So symptom management continues throughout the disease course, whilst you're also looking through effective disease-modifying therapies. So there's different things that you manage with MS, different symptoms. And so we'll go through those one by one, and then we'll end off with the disease-modifying therapies. So you really want to make a plan for rehabilitation, and you want to put together your interdisciplinary team. And if you don't have one at your hospital, you can always consult and outsource. So we start off with fatigue. So many patients who have fatigue, and it will be very, very disabling. And it's quite common as a problem that even keeps people from working. That alongside the cognitive problems. And of course, you have to remember that there's much misunderstanding from amongst family members and employees, and sometimes can be looked off as laziness. I've seen health workers before who have MS whose employees thought this is just a lazy doctor who cannot handle being on call, who can't handle standing in theater. So it's something that can be very easily misunderstood. So what we do is you try different things to try and help. And what's important is to identify what contributes to this fatigue. So make sure the patient doesn't have disrupted sleep. There may be just muscle fatigue from muscle activation through different activities. Maybe you spent the whole day lifting heavy crates from one room to another. Then other disability-related fatigue, maybe you've got a paralysis and that's what's causing the actual fatigue. Mood can also contribute to fatigue if you're depressed, and there may be also a contribution from medications. So what you do is you want to conserve energy. So you prioritize and plan certain activities. you use mobility aids and you modify the environment around you. So if you have to, move your room from upstairs to downstairs, maybe if you're in a situation like that, you ask for desk work that's downstairs. We've had to do that for some patients at their workplace. If their office was upstairs, move it downstairs that they don't have to use stairs. Regular exercise can really help with that, and certain medications may help, like amantadine, modafinil, and methylphenidate. So weakness is also important to manage. So sometimes there may be functional electrical stimulation if there's a foot drop in some patients. Then there's temperature sensitivity, which is a very big problem with patients who have MS. So what this means is when the temperature goes up, in most cases, increase in temperature tends to exacerbate relapses, and symptomatology in MS tends to get worse with the heat. So around October and just around the hotter times of the year, patients with MS tend to do very badly, and this is called heat intolerance or heat sensitivity. It is very, very common in MS patients. In some rare cases, the sensitivity can go the other direction, in which things get worse when it's cold. So what you need is to really avoid warm temperatures. So use the aircon as much as you can. Advise the patient to use the aircon. Cold showers, not too hot, not hot showers, not hot baths, but actually cold showers. And also there is something we call cooling vests, which can be worn in very hot climates such as ours. Drink lots and lots of cold liquids and just maintain your body temperature below. Then you have visual impairments from optic neuritis. So you may have dimming vision, you may have blurred vision, you may have blind spots, and difficulty with contrast sensitivity. And it's very, very important that the patient is not allowed, if they have no symptoms of optic neuritis, to eventually develop this, because it can be very, very debilitating. And so early diagnosis is very important for managing this. Bladder dysfunction is very common. So very, very common. Over 75 patients with MS will have bladder problems, and this will be difficult controlling the bladder. So they may be incontinent in public, and this can be very, very embarrassing, and it can cause real problems for the patient and may result in social isolation. So what you want is to help the patients with this very, very big problem, and it starts off by understanding the different ways that it manifests. So you may have patients with small quantities of urine that end up causing an agency to pass urine. And so it feels like the bladder is smaller than usual. And so those symptoms could manifest such as agency, frequency of urine, incontinence, and nocturia. So we often use for such problems anticholinergic or antimuscarinic medications. So you can use beta-3 adrenergic agonists for treatment. Sometimes we use botulinum toxin, or we use pelvic floor physical therapy. So all these can help if your patient presents with agency, frequency, incontinence, or nocturia. If your patient has got problems with emptying the bladder, they are at a high risk of UTIs. So make sure that you look out for those, because they're very, very common. And sometimes you may use intermittent self-catheterization, which there's a kit for that, and you can show your patient how to do that to help with bladder emptying. So you can also have constipation from the bowel. It's very, very common. So you can also have loose stools due to impaction. So once there's impaction and then the loose stools at the top, once you release that impaction, you can have loose stools, but by and large, you get constipation. Bowel incontinence is much less common than constipation. You can have patients take adequate fluids and adequate fiber, eliminate the time between opening bowels. So you have to have regular bowel movements to try and reduce on filling up of the bowels. Exercise helps with gastric and bladder motility. And then you can use over-the-counter products as needed. Anticholinergic medications can also manage the incontinence. Spasticity in limbs is a very common problem. So stretching can help. Medications like baclofen, tizanidine, clonazepam, gabapentin, cyproheptidine, and other dopaminergic agonists can help a lot with this spasticity. You can also have a baclofen pump that regularly gives the baclofen, or you can have Botox injection, nerve blocks, or surgery in very severe cases. And remember, some spasticity can be useful to counteract weakness. So if you have weakness on one side, spasticity on the other side could help with keeping the patient mobile or somehow managing themselves. Primary sexual dysfunction is a very big problem. So patients may have reduced libido, and they may have different loss of sexual function. And it's a problem for both men and women. So for that, you can have strategies that help, with stimulating sexual desires, sexual function for reduced libido. So some strategies with behavior and the environment, and you can talk to different sex therapists and other therapists, as we mentioned above. This is very multidisciplinary approach. If there's any sensory disturbances that may be impeding sexual dysfunction or sexual function, you can try anticonvulsant medications. The lubricating gels that can help with women. As you know, lubrication within the vagina is very important for sexual function in women. And if there's erectile dysfunction in men, you can use pharmacological therapy with tadalafil or sildenafil, or you can use implants. These are implants in which pumps and balloon pumps are inserted in the shaft of the penis, and they are inflated manually before the sexual act. Of course, you can use the other contributory factors to sexual dysfunction. And so fatigue, the spasticity, and the bladder dysfunction can be a huge contributing factor to sexual dysfunction. And then you can try anticholinergics medications as a cause of the sexual dysfunction. Antidepressants, fatigue, and spasticity medications can also cause difficulty responding to sexual stimulation. Then you can have other dysfunction in which your attitude and you just need some education and some counseling as a cause for the dysfunction of the problem. So there could be problems directly due to MS. Those are the primary sexual dysfunctions. Others are problems that are arising because you have MS, such as the secondary and the tertiary dysfunction. Cognitive decline or dysfunction is also very, very common in MS. It ranges from mild to very severe. And if the lesion burden is high, then you have also got more cognitive decline. If you have a large area affected, or if there's brain atrophy, then the cognitive function reduces as well. It can occur at any point in the course of the disease, and it can occur in any of the 3 types of MS, relapsing, remitting, or the 2 progressive types. There is an exacerbation with different manifestations. So if you get a flare, if you get an infection, if you get a stressor, it can exacerbate cognitive dysfunction. The most common problem is memory, attention, concentration, and information processing. To do that, disease-modifying therapies are very helpful, and cognitive rehabilitation will be very important. Depression is a very common symptom, so you want to manage that with antidepressants and also counseling. 50%, of course, will experience it. And MS can increase the risk of suicide twofold than the general population. So this is something that you must be very aware of and manage very closely. Pain is another very important symptom, so you may need to manage this. Remember, it's a neuropathic central type of pain, and it may come in paroxysms, and it may be continuous. For the paroxysmal pain, that may be like a trigeminal neuralgia or headache, use anticonvulsants. For the continuous pain, you can use the tricyclic antidepressants like amitriptyline or anticonvulsants. Then you have nociceptive pain, which is mostly within the limbs or peripheries, and you can use that. You can use NSAIDs or physical therapy for those. And you can manage the spasticity to help with the pain as well, because there's a more likelihood of pain with spasticity. Speech problems are very common. About 40 to 50% of patients experience them. So this could be dysarthria. So that's the problem with articulation or emphasis of your words. And dysphonia, where the voice quality changes. There's poor pitch control. It sounds breathy or breathiness or hoarse when you speak. So there's also language problems with MS that you have to watch out for. So when you assess the patient, you need to look out for oral peripheral examination, voice evaluation, and the communication profile. And exercise can help with this, as well as other strategies and techniques to improve the speech quality. So speech therapists can be very, very helpful with this. And if necessary, you can use an augmented device if needed. Dysphagia or swallowing problems are not as common with MS patients, but they should be done. You should still do a swallow assessment. And if necessary, you can do exercises, modify the diet, and change position when eating or chewing. And sometimes you may need non-oral feeding options, such as a PEG or a feeding tube through the stomach. Tremors, as I mentioned, is a very common symptom. And it's something that you can look out for with ataxia in a patient with MS. It can be quite disabling in some patients. There are unfortunately no good treatments, excuse me, for tremors in MS, but you can try propranolol, primidone, acetazolamide, buspirone, clonazepam. You can also try weighting of the limbs affected, so you can see maybe if it's in the hand, you can put a heavy bracelet around the hand to try and weight the hand to reduce the severity of the tremor. And you can use assistive devices for those with severe morbidity. Thalamic surgery can be tried, but the results are generally poor. Serious complications of MS include urosepsis, aspiration pneumonia, pulmonary dysfunction, skin breakdown, depression, which can result in suicide, and osteoporosis. And you want to balance out all of these activities and all of these rehabilitation efforts and all of these symptoms together. And that's how a patient's quality of life improves. You can couple this with rehabilitation and some exercise, eating well, avoid the heat, as I mentioned, drink lots of water, just be generally healthy for your age group, manage any stresses that come that can cause psychiatric or physical problems, and just be aware of the common emotional reactions. Also, you can do well to join a group, so that you're not by yourself. We have support groups here in Zambia for patients with MS. Stay connected, don't be socially isolated, and this can help with managing the patient's well-being. And finally, we look at disease-modifying therapy. So there's a long list of medications here, and these are the ones that are approved for disease-modifying therapy in MS. These ones are effective on relapses and progression of disabilities. Another long list. But I wanted us to focus on the medications that we can use here in Zambia. So we use rituximab as one of the only drugs available from this list. Of course, with time, we'll probably get a few other drugs. And compared to, if you look at the list, if I went back to the list, you have ocrelizumab / rituximab on our list on both tables. And so since we have rituximab available, there's some literature that shows that rituximab is an acceptable alternative to ocrelizumab for treating MS. And so this means that with our availability of rituximab in Zambia, rituximab alone is a good alternative to use, and this is the one that's available here that patients receive. And again, if you look at the comparison, it's cheaper than ocrelizumab, and it is available through most support, and it's also available here in Zambia through the Cancer Disease Hospital. So that is my lecture on multiple sclerosis. Thank you for joining this class, and I hope it was helpful. Thank you very much.